I think one of the things that still bothers me is I think we have a regimen with the ATG cyclosporin and eltrombopag that has hit really high marks in terms of overall and complete response rates. Obviously, we can always improve upon that. But in terms of response rate, I think we're pretty up there. What we would like to see is that these patients are having these type of responses without having to be on therapy, which I think is something that is also evolving. And also not have these long-term complications of clonal evolution, for example. That's something we have worried and we have monitored. Now, the rates so far of these late events have been around 8 to 10%, which is very, very in accordance to several reports, including from the United States, but other places with hundreds of patients. So that doesn't seem, at least to date, to have, in terms of cumulative incidence, gone higher. But I would like that number to go to 0. So that you could put probably that as an unmet need. Now, we don't understand all the mechanisms that are involved for clonal evolution, so it's harder for us to address that. But from a safety point of view, at least to date, we have seen something in accordance to what we have seen historically. The other thing that, along those lines, that I think would be interesting is to incorporate other biological information or markers that could predict a little bit better, more consistently across studies, the patients who will respond that will have these later complications, either doing molecular studies or genetic studies or telomere length or PNH or some other pieces of information that would help us better define those risks and incorporate them into the treatment algorithms, because as I said earlier, we're still using age and the availability of a donor still to make those decisions. So I think the reason we haven't incorporated those is because the data has not been terribly consistent, so we worry, obviously. You don't want to incorporate something that might not be right, because you're making major decisions and you're advising people to make those decisions based on that information. So you want to make sure that this is pretty tight. So I would think that my view of the unmet needs would be more in terms of those, some of these later complications and the incorporating more biological information into our treatment decision algorithms. So in terms of new development and ongoing development, I think there are several things ongoing involving these class of agents, like the thrombopoietin receptor agonists. There are several trials that are ongoing, understanding that there are other interests associated with the management of these patients. So let me give you a few examples, all right, things that are still open questions. So if we talked about eltrombopag in refractory patients, right? Somebody failed the immunosuppressive therapy, you put them on eltrombopag. Would adding cyclosporin to that be better than just giving eltrombopag alone? So we don't know. But that's something that people are very, very interested. What about if somebody failed immunosuppressive therapy and you want to give eltrombopag with cyclosporin and ATG again? Is that better than just giving eltrombopag alone? So these are questions that I think are important. Some other questions would be, do you need ATG at all? I mean, can you just give eltrombopag cyclosporin? Could that benefit some patients? ATG can be a hard drug to give, especially in older populations, comorbid patients. But do you need that in younger patients? I mean, could you get away with ATG? I mean, most places don't have horse ATG. And sometimes countries that have ATG, they don't have it available in their center. So could you get away with doing 2 drugs like oral outpatient regimen with cyclosporin and eltrombopag? So we don't know that. That's being investigated. What about the role of eltrombopag to rabbit ATG cyclosporin? So that's also a question that's being answered in the context of a clinical trial. So, so there are these questions, and there are all these trials worldwide that are being conducted. Romiplastin is the other thrombopoietin receptor agonist that is also being investigated in a much earlier preliminary fashion. But that would be a question that also would be of interest. Now, there are some preliminary data to suggest that it has activity. But very few patients, only published in abstract form. So we have to, far less developed than eltrombopag, but that's something that is also currently being investigated. Pediatric patients, not a lot of pediatric patients included in these trials. There is activity in that setting, but how active? So there are pediatric dedicated studies that are actually ongoing in the context of clinical research that will help answer this question. And And then there's a large European study comparing horse ATG cyclosporin versus horse ATG cyclosporin L-Tromapag randomized 1-to-1 that is about to complete accrual, and that will also give us a lot of answers in terms of the comparativeness between these two regimens, and also long-term outcomes. Could other agents be added to this backbone, like androgens, to L-Tromapag and cyclosporin and ATG? So these are all ongoing. So there's a lot still that we would like to have answered. Now, there's many trials addressing these questions. Not all of these questions, but several of these questions. So when you ask me what do I see in terms of development, I think this is a very exciting time because this is worldwide development, several centers in countries around the world addressing these different questions. So in 2, 3, 4, maybe 5 years, we'll definitely have a lot more answers and better have more informed data or data to inform us actually how to better incorporate all these different possibilities into our treatment algorithms to provide the best care and the outcomes that we can for our patients with this once universally fatal disease. So we can't forget that aplastic anemia killed almost everybody back 4 or 5 decades ago. Now most patients are actually alive. So the natural history of the disease has actually changed dramatically. So this is a success story of modern medicine. But we obviously want to keep continuing that and improving even more. So I think there's a few important messages. One is that L-Tromapag adds to the armamentarium of treatments in the past few years as a single agent with activity in refractory aplastic anemia. So that's obviously an important addition. More recently, with the incorporation of horse ATG cyclosporin with L-Tromapag, also an option in upfront therapy. So this is something that we'll have to see how this will be incorporated into people's day-to-day life. So it's a very exciting addition to what we had before. It's important for the community physician who actually is using these type of therapies is to pay attention to some of the important practical aspects of giving this drug. There are dietary restrictions associated to L-Tromapag. So you have to have it 2 hours before or 4 hours after a meal. I say that because I see patients coming to me who are not following that. And I think that this is being affected, their absorption. And monitoring for liver function test abnormalities in about 10% of patients. So these are more practical day-to-day for the community hematologists. Most patients can tolerate this regimen. Few patients have to have their drug discontinued for a few days. They tolerate usually resumption. But the 40–50% response rate in the refractory setting and the added benefit in the upfront setting, I think, are the major take-home messages that I think people should take from this. All this data actually that we have actually been discussing here for this activity.